Thank you so much for having me, and thank you for joining us today. So today I'll be talking about our project, which is where we estimated disease heritability using familial relationships that were inferred from electronic health record data. So this talk will be divided in two parts. The first one, I'll describe how we identified familial relationships using existing data from electronic health records. And then I'll explain how we use these relationships to study heritability of clinical traits. So electronic health records are used every day as the system of record to support clinical care. And in these systems, we collect patient demographics information, such as race, ethnicity, address. We collect medications that patients are taking, reported allergies. We also collect immunization history, the results of their lab tests, radiology reports, vital signs, billing information, and this list goes on. So there is a lot of information being collected every day for every patient that is coming to a healthcare system. Currently, with federal initiatives such as the CMS Meaningful Use Program, electronic health records have been widely adopted in the United States. And now that we have all this data, but the problem is that these electronic health records are not organized by families. So just to give you a little bit of background, family history is considered a core element of clinical care. It has been described as being a free genetic tool that almost every patient has access to. And it plays a very important role in precision medicine because the knowledge of family history information allows us to give more individualized disease diagnosis, treatment, prevention. However, as I mentioned before, the electronic health records are not organized by family. Right now, the records of family members are not currently linked together. And so what data could we use to tell us a little bit about the shared genetic background? So right now we have race and ethnicity data, which is known to the gold standard is self-reported race and ethnicity data. It's in the electronic health record, sometimes this data instead of self-reported can be staff assigned. And we, in our institution, more than 40% of our records that have race and ethnicity information are uninformative, meaning race and ethnicity were collected and the data that we see is either described as other or as unknown. There is a more reliable source of information that is collected at every single hospital, and that's the emergency contact information. It is part of hospital processes to collect an emergency contact at the time of admission. And patients are asked to provide somebody's name, phone number, their address, as well as the relationship between that person and the patient. So here at Columbia, we have about 2.5 million emergency contacts. The majority of these contacts are part of the patient's nuclear family. So we see mother, father, spouse, child, and sibling. So we used these emergency contacts and we developed a method that we call RIFTER. So it's a relationship inference from the electronic health records to extract families from existing clinical databases. Our paper, as it was mentioned before, is available at bioRxiv. And the version over there will be very soon updated. So how does this method work? So we use the emergency contact information. As I mentioned before, it contains first name, last name, phone number, zip code, as well as the relationship between the patient and the emergency contact. And we try to match this information to the list of patients that we have at the hospital. We only consider a match if we identify a unique patient that matches any of these elements or any combination of these elements. So if we find more than one person matching, then we don't consider it a match. We have to find a unique person in our patient list. The assumption here is that families oftentimes use the same healthcare system, and therefore the emergency contacts provided could also be part of our patient list. So once we identified this relationship, we looked here at Columbia and we found about 1.1 million matches. And you can see here the list. Some of them are very informative, such as mother, spouse, father, but others are not very informative, such as relationship unknown, or even relationship self. That's not very helpful when trying to extract familial relationships. So what we did is we used the ones that are interesting, the ones that provide us with information, but it doesn't end there. Once we identify relationships, we can also infer additional relationships. So for example, if two people in this list the same person as their mother, then we can infer that those two people are siblings. Very similarly, if somebody lists the emergency contact as their mother and their mother has a sister as emergency contact, then we know that that's person's nephew. And we could go even further. For example, if somebody has his mother as emergency contact and that mother has a spouse, then we can even ask if this is this patient's dad. So you can see that we can infer many more relationships from the ones that were provided as emergency contacts. So that's what we did. So we looked at, when we look at the total relationships provided and inferred here at Columbia, we identified about 3.2 million relationships. We did the same thing at Cornell, and at Cornell we identified 1.5 million relationships. And again, we used the method as well as using the data from Mount Sinai. And over there, we identified about 2 million relationships.
Wow.
The majority of these relationships are from the nuclear family, such as parent, child, sibling, and spouse. And overall, these relationships account for more than 595,000 families. So that's the number of families that we have currently. These families, so this is a pedigree, which is the classical representation of family history. And in the pedigree, as I'm sure many of you know, men are represented as squares and women are represented as circles. The patients that we have electronic health record data for have a solid outline around them. And the ones that we don't have, they have a dashed outline around them. Some of the families are just as big as this, including up to 4 generations. And here is another example of a pedigree that was also extracted using emergency contact information. Again, the solid outline represents patients that we have electronic health record data for. And you can see that it can be pretty complex. So once we identify these relationships, we evaluated these relationships using clinical data. So both at Columbia and Cornell, we have something called the mother-baby link. It is a link that is manually created by clinicians for newborns at the hospital. It links the baby's chart to the mother's chart, and it's used for clinical purposes. We have about 40,000 of those links in each one of the institutions, and we use these links as the gold standard to evaluate mother-child relationships. We achieved about 96% positive predictive value at Columbia and 98% at Cornell, which demonstrates that these relationships are actually real. So, but this only allows us to evaluate the mother-child relationships. So to evaluate other types of relationships, we use genetic data. These results are using genetic data available from Mount Sinai. We identified 922 patients that have genetic data at Mount Sinai that was consented for reuse. And these patients also had relationships inferred from the electronic health record. So you can see here that overall parent, sibling, grandparent, grandchild, they perform quite well. And we have very few patients that for us to evaluate cousin, as well as great-grandparent and great-grandchild. But overall, it performs really well. We did the same analysis at Columbia. At Columbia, we identified 185 patients that had genetic data available and the relationships, as well as relationships inferred from the electronic health record. And we find very similar results where parent, child, and siblings perform really well. And at Columbia, because of the sample size, we didn't have a lot of patients to evaluate other relationships. So now that we have all of these relationships and we have these families with electronic health record data, we wanted to study disease heritability. So heritability tells us how much variability in a phenotypic trait can be attributed to genetics. And why would we want to use electronic health record for this? So in this case, phenotypes are going to be the clinical phenotypes. And when we look at, let's look at different traits and compare the published studies, so how many patients they had in published studies looking at heritability, and how many patients do we have at Columbia with the same trait. So for example, height, published studies have about 20,000 patients. Here at Columbia, we have 300,000 patients with this information.
Wow.
If we look at diabetes type 2, studies are about 20,000 patients. Here we have 100,000 patients. Eczema, 10,000 against 80,000. And asthma, the same thing. We can increase the sample size by quite a lot. We have 150,000 patients with asthma. Depression, ADHD, rhinitis. And this is only Columbia. When we look at Cornell, we have additional 75,000 patients with the trait for height, for example. So it really can increase by a lot the sample sizes of these studies. How is heritability usually estimated? So we have twin studies that compare the phenotypic correlations of monozygotic and dizygotic twins. We have other pairs of relatives, in studies accounting for other pairs of relatives, where we compare the phenotypic correlation to what should be expected by genetics. We have studies that uses entire families of individuals using mixed linear models to also estimate heritability. But there is a difference. So traditionally, in a family study, we identify a proband, and then we recruit the family members, and we determine if they have or don't have the phenotype. And the phenotypes that we don't know or they're missing are clearly marked. So it's a very well defined cohort of patients that we actually know if they have or not have the phenotype. Whereas in the electronic health record, we don't really have a proband, and the probability of phenotyping is not going to be the same in every single family member. So in this case, we have the uncontrolled ascertainment bias. This will vary. This bias will also vary from patient to patient, from family to family. It depends on maybe how far that family is from the hospital that we have data for. So that's something that we have to keep in mind when using electronic health record to estimate heritability. So because of this, we introduced a new concept, which is what we call observational heritability, which is an estimate of the heritability where the phenotypes are coming from observational data sources, existing clinical data. And the way we control for these ascertainment biases is by repeated subsampling of the family. So for example, here a trait with heritability of 50%, we increase the number of family samples until the estimate converges. And these methods, that's what we call SOLARStrap. We're using SOLAR, but instead of simply using SOLAR, we are bootstrapping. We analyzed what would be the impact of SOLARStrap in the presence of ascertainment bias. So using simulated data, we introduced bias in the data set, and we ran SOLAR and SOLARStrap, and we compared the two. And you can see here that SOLARStrap is robust regardless of the presence of ascertainment bias, while SOLAR was sensitive to ascertainment biases. However, SOLARStrap does produce larger confidence intervals. We also analyzed the effect of missingness from SOLARStrap. So here we observe that SOLARStrap overestimates heritability when we sample all of or almost all of the families with the trait of interest. So because of this, we use 15 to 30% of the available families with the trait of interest to compute heritability. So once we computed heritability for a number of traits, we also compared our results with the available literature. So for example, a meta-analysis that was published in 2015 reported heritability of height to be 77%. We obtained the same results when running heritability using the relationships inferred from the electronic health record and height extracted from clinical data recorded in the electronic health record. And this analysis of heritability does not take into account the known literature. So the algorithm does not see what the literature knows about the heritability itself. We just compared once we had our estimates of heritability. So we looked at different traits. So for example, if we look at coronary artery disease, a prior study reports heritability of 49%, and we achieved 51%. When looking at depression, we saw the report from the meta-analysis was 39%. We achieved 36%. Rhinitis, it is reported in the literature to be heritability of 95%, and we see here 78%. But some traits don't perform as well. So for example, atopic dermatitis, the meta-analysis reports 78% heritability. We got 41% heritability in the electronic health record. Similarly, bipolar disorder, we got, they report 70% to be 70% heritable, and in the EHR, we see 22%. So overall, the observational heritability is 7 to 20% lower on average. We looked at what would be the impact of missing or missed diagnosis that could explain the missing heritability. And we see here that when we have noise from 10 to 15%, it affects the heritability between 5 to 20%. So this could explain why we see our estimates are a little lower than what is reported in the literature. So overall, we identified significant heritability estimates for 534 traits. These traits include 129 that are quantitative and 405 that are dichotomous. They involve 12 different physiological systems, 15 disease categories. And so what we see here is that the electronic health record is a very valuable resource of phenotypes. The relationships that are being derived from emergency contacts are real. We validated those relationships against clinical information as well as genetic. And we identified a positive predictive value that varied from 71 to 99%. It is a valid method for estimating heritability of traits without using genetic testing. And we identified 534 traits with significant heritability estimates. So with that, I would like to thank my advisors, David Wadley and Nicholas Sadmetti, as well as the co-authors and collaborators. And I'll be happy to answer any questions. Thank you.
Thank you, Fernanda. This was a great talk. If you want to, you can stop sharing the screen. Are there any